Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Grand Rounds this week, where Dr. Kelly Fedoruk, an obstetric anesthesiologist with active work in quality improvement, POCUS, and simulation at Stanford, discusses the role of the obstetric anesthesiologist in improving maternal health quality. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So the title of my rounds is Quality in Maternal Health, Evolution of Data, Metrics, and the Role of the OB Anesthesiologist. So this topic is near and dear to my heart. As Henry mentioned, it's my focus in academia at Stanford. And it's hopefully going to be a testament to encourage the need for more OB anesthesiologists in this world. So the objectives that we've circulated are listed here. So we'll review data on the state and quality of maternal outcomes in Canada and the US, look at the evolution of quality metrics in OB anesthesia, and also look at some optimal metrics that we might want to use locally on our labor and delivery units. So it's been a minute. For those that don't know me, as Henry mentioned, I finished residency in 2016 here with these guys. You might recognize a few. And then I actually went to Stanford for my OB anesthesia fellowship, just a correction, but ended up making my way to Toronto afterwards to work. So doing an OB anesthesia fellowship was a very transformative experience for me professionally as an anesthesiologist, but also as a person. I had amazing educational experience. That's me on my first day of fellowship there. I made amazing friends, and I also met my now husband, Paul, and that's how I ended up back there. After my fellowship, I did work at the University of Toronto for a few years at Sunnybrook Hospital. So it's Canada's biggest trauma hospital, where working as a new attending, it was definitely baptism by fire, but I also did a lot of high-risk OB there and definitely learned some valuable things. And then I found my way back to Stanford in 2020. I had a 6-month locum here, which was really awesome to reconnect. But since then, I've taken on the role of the Director of Quality Improvement, and as mentioned, I do some work in SIM and POCUS. So now, as much as doing an OB anesthesia fellowship was transformative for my job, it made me more passionate about maternal health, but nothing compares to when I became a mother. Paul and I have 2 girls, Gabby's 2.5, and Anna just turned 1. So in addition to being the lights of my life, they've also emboldened my mission to expand access to quality care for mothers. So I mentioned my role as the Director of Quality for our division. And this is something I never would have dreamed of building my career, and it sounds like something very dry and very boring. But part of the reason that I fell into this is because of this well-described phenomenon, that there is a 17-year gap between the time that we describe an effective and evidence-based intervention, typically at these ivory tower institutions, and large-scale uptake into our community practices. So I found my passion point to be the translation and implementation of high-level research into general practice, and I use QI and implementation science to do this. So you'll notice from my objectives and the title of these rounds that I'm pretty keen on metrics. Now, this isn't a talk on QI methodology. It's far too early for that, but I do think that any talk on quality requires some mention of the bread and butter concepts. So metrics have become somewhat of a buzzword. So to make sure that we're all on the same page, the way that I'm using them aligns with these concepts. So they are specific measures. They're used to assess performance, effectiveness, and outcomes. And defining metrics will allow us to identify opportunities to improve, measure progress, and then make data-driven decisions that will enhance the quality of our care. Here are a few of the types of metrics that we use. So outcome metrics are used fairly commonly, and this is what we most often see quoted with statistics. They are the ultimate results of a process or an intervention. Examples would include mortality rates, complication rates, satisfaction scores. Whereas process measures are used to assess efficiency and effectiveness of a specific process. Examples include wait times or adherence to guidelines. And structural metrics evaluate resources that you might have available for care. So this would be like workforce, staffing levels, equipment availability. This list isn't comprehensive, and I will go through a few more as we move on. So now we arrive at the first objective to look at the current state of maternal health in the US and Canada, also a little bit globally. So anybody who's taken even an intro course in QI knows that the first step is always to define your current state and identify whether you have a problem before you can make any change and achieve your target state. So do we have a global problem in maternal health? We do. So worldwide, we know that 830 women die every day from preventable causes. Keyword is preventable. And this brings us to the most well-known and perhaps most important outcome metric in maternal health, the MMR, the maternal mortality ratio, which is defined by the WHO as the number of maternal deaths during a given time per 100,000 live births. So it's the most commonly used measure of maternal mortality, and it's an indicator of the risk for death once a woman becomes pregnant. Now, although MMR is the most commonly used metric, there are some others that are important to acknowledge because they do come up in the nuance. So a maternal death is one that occurs during pregnancy or up to 42 days postpartum. It's a death due to any cause related to or aggravated by pregnancy, but it excludes accidental or incidental causes of death. So examples of these would be your more classic causes of maternal death, like hemorrhage, infection, thromboembolic disease. Whereas a pregnancy-related death captures the same timeline, so pregnancy to 42 days postpartum, but it includes those incidental or accidental causes. So examples would be cardiac disease worsened by pregnancy or a placental abruption from an MVA. And then lastly, a late maternal death is one that occurs after 42 days postpartum up to a year. So it's really during that first year postpartum that we're capturing it. Examples of these would be like peripartum cardiomyopathy or suicide. So what is our current state when it comes to maternal mortality worldwide? Well, the UN announced a series of sustainable development goals in 2015, and these served as a call to action to end poverty, protect the planet, and close gaps in that we have pertaining to human rights. So it's a framework for countries and GMOs to work together for a more equitable future. And one of the key goals pertains to achieving good health. I have that circled there. And this is where we see maternal health and the maternal mortality worldwide being tackled. So at the time these goals were made in 2015, the global MMR was 216. So that's 216 deaths per 100,000 live births. So that's the current state. And the target state to reduce this to 70. So 70 maternal deaths per 100,000 live births by 2030. So how are we doing in regards to this goal? So this data is from 2020, and it displays whether targets have been reached, which is the most pale colors. So you can see that most of North America, Western Europe, a lot of Oceania have reached that already. And then the dark colors on scale correlate with areas where there is the highest worldwide MMR. So you can see that most of Africa and parts of Asia and the Middle East still have not achieved that goal. But looking at this a little closer, how are we doing in Canada and the US? Well, you've likely famously heard that the US is not doing very well in regards to maternal mortality. So recall that the goal MMR by 2030 should be less than 70. The US has met this, so our MMR is estimated to be around 17, but it's much higher compared to other high-income countries. Per this data, Canada is largely tied with like France and close behind is the UK with an MMR of around 8.5, but we're going to look at some of the data with scrutiny in regards to this as well. So not only has the US MMR been described extensively in the literature, but it's very much hit the mainstream media. You can really rarely go a week without seeing articles similar to these highlighting the issue of maternal mortality in the US. And then the same applies to the racial gaps that occur in the US. So we know that Black and Native American women have MMR rates that are much higher than their white, Asian, and Hispanic counterparts. In fact, the MMR of a Black woman in the US is similar to the MMR of like a middle-income country like Brazil or Uzbekistan, whereas that of a white woman is comparable to countries that are farther down on that graph, including the UK and Japan. So what's happening in the US? Is it because of our two-tiered private healthcare system, poverty, racism? All of this is probably contributory, but there's something very nuanced in the data that's worth pointing out. So in 2003, per the guidance of the WHO and the ICD, the US adopted the quote pregnancy checkbox on death certificates. So after this point, the option for a death certifier to acknowledge whether the deceased was pregnant at the time of death within 42 days or between 43 days and 1 year, so a late maternal death. And the US began to capture maternal pregnancy-related and late maternal deaths after this. So prior to the addition of this checkbox, as many as half of all maternal deaths probably weren't identified through the cause of death information on death certificates. Medical certifiers often didn't provide enough information to indicate that a person was pregnant at the time of their death or recently pregnant before that. And although this was introduced in 2003, it wasn't fully implemented across all US states until 2018. So over the past 20 years or so, there's been a major overhaul in the data collection across the US, the quality and the methods of analysis when it comes to mortality data. And this has led to, at least partially, this massive increase in the MMR. So it's been suggested that there are two things at play. Prior deaths were probably underestimated, and there was a significant amount of catch-up required, as you can see displayed as the different states took on this pregnancy checkbox. And now new rates might even be overestimated because there still is a lot of confusion around filling out these death certificates, and there's a lot of errors in completing them by certifiers. So what is happening in Canada? Well, we don't actually really know, but maternal mortality is likely a lot higher than we think, and that is being quoted by Stats Canada. In fact, the WHO estimates that Canada's maternal mortality rate is 60% higher than what is reported by Stats Canada, and they actually apply this correction factor whenever they report our data. So you can see here that Stats Canada estimated our MMR to be 6 in 2017, but WHO actually corrected that to 10. Why would this be? So there's a number of reasons that a maternal death might slip through the cracks in Canada. Our death certificates have very little oversight, and it's estimated that they are probably more often than not incomplete when it comes to details about pregnancy. Perhaps more alarming is that we don't have a uniform definition of what counts as a maternal death. And the definition, the information recorded is going to be different depending on the province or territory that it occurs. So for example, BC counts deaths up to 1 year postpartum, whereas Saskatchewan includes deaths up to 90 days postpartum. Quebec only counts them up to 42 days postpartum, and the Yukon Territory doesn't record any information about pregnancy at all in their death certificates. So because of this, the SOGC and related organizations have been calling for national oversight on this data for years. So who's doing it right? Well, it turns out the UK has become a model state for the rest of us when it comes to tracking not only maternal mortality, but also near misses, and also implementing a system to provide surveillance over this data. So nationwide initiatives in the UK surrounding maternal health have actually been in some format or another since the late 1800s. So the government at that time actually mandated what they called medical enquiries at the turn of the 20th century. And this involved incredibly thorough investigations of any death that might be related to a pregnancy or in the postpartum state. So we can see here that maternal death rate dropped significantly over the century, as it had done in most parts of the world, largely due to advancements in infection control, but also in part to the surveillance program that was brought about by these enquiries. So this program was formalized and written into legal policy in the 50s, and it's undergone several iterations, but it is a government mandated program that has to occur. The most recent iteration was formed in 2012, and it's called Embrace UK. That stands for Mothers and Babies Reducing Risks Through Audits and Confidential Inquiries across the UK. And currently, this group conducts confidential inquiries into all maternal, infant, and stillborn deaths in the UK. And they oversee the collection and analysis of the maternal data and report their findings about every 3 years or so. So they provide really detailed reports to medical professionals and policymakers, but they also produce a report for the lay public in order to empower pregnant people about the current state of the quality of maternal care. You can see from 2023, this is the summary that went out to the lay public. There were obviously lessons learned from COVID-19 at that time and some alarms around that. But they also detail that the same racial and socioeconomic disparities exist in the UK, and they have some data on that. So as mentioned, they report their findings to medical professionals, and they do include a quote message for improving anesthetic care. And we can see that in the time frame that they reported on, anesthesia-related deaths, which were only indirect, none of them were actually direct, made up the minority of causes of death in that time. So despite that, they actually do still drive home some takeaways and offer some themes for anesthetic practice. And examples include anecdotes and specific recommendations from cases about failed block management or obstetric hemorrhage. So California clued into the success of this program in the early 2000s, and keep in mind that the UK has been doing this since the 50s. And it was the first US state to implement a similar surveillance system. So ours is called the CMQCC, or the California Maternal Quality Care Collaborative, and it was started at Stanford in 2006. It's a multidisciplinary organism that is committed to ending preventable morbidity, mortality, and inequity in California. This is a screenshot of our website and a list of the QI initiatives that we currently have. This website is free to access, but you do need a login for it. It's really an amazing resource because it offers protocols, flow sheets, debriefing tools, basic quality improvement projects if you're just getting started. But most of this is surrounding implementation uptake of this evidence-based practice throughout our community. And this is why I love improvement science, because simply bringing this nicely collated evidence-based practice toolkits across the state, and these were at the very early on time targeting hemorrhage, hypertension, infection, kind of the basics in maternal mortality. The CMQCC was able to reduce the California MMR by 65% between 2006 and 2016. And this was despite the uptake of that pregnancy checkbox and also the really rising rate of the MMR across the US. So it's quite a success story. And it's been inspirational across the US. So currently 30 states have some sort of surveillance program like this. The one in the middle is AIM. It's the Alliance for Innovation on Maternal Health, and that's endorsed by ACOG and the ASA, and it's more of a national body. Also open access, amazing QI toolkits there if anybody wants to look. So in Canada, currently 6 provinces have a maternal death review system, which means that if a woman dies in the other 7 provinces, there wouldn't necessarily be an independent review of her case. These exist in BC, Alberta, Manitoba, Ontario, Quebec, and Newfoundland and Labrador. And similar to the SOGC's call for improved data collection on maternal mortality, they're also calling for a nationwide surveillance system in regards to maternal mortality as well. So this recommendation has actually come from the WHO saying you guys should probably set this up. They acknowledge that despite 6 provinces having these programs in place, we don't have a national system that can synthesize this and then report on trends and themes that we can build into our policy. So we really don't have an accurate national picture for prevalence and trends right now. This article came from SOGC, and this is them providing an update on the establishment of this because they do have a working group. 2019 was the last time that I saw anything published, and I imagine that COVID probably had a lot to do with any stalling of efforts there. So where do we as anesthesiologists fit into all of this? Do we have any responsibility when it comes to accurate data collection on maternal deaths? Do we have a role in reducing these numbers or being part of these surveillance groups? So with the growth of our specialty, so came the growth of our role in preventing and reducing maternal mortality. We've expanded our role outside of the technician who places epidurals and spinals, and we've evolved to being fierce advocates for maternal safety and peripartum health. And in fact, a lot of us are changing our division names to include this peripartum health and maternal health specialist because we're really taking on more of the global picture of the specialty. So the ASA's Committee on OB Anesthesia came together in 2022 with a statement that outlines some particulars regarding our role in reducing maternal mortality and severe morbidity. Some of the salient points include the following. A physician anesthesiologist should be an active member of maternal review committees, be an active member of quality committees, lead SIM, multidisciplinary SIM, particularly for maternal emergencies, perform timely consults on high-risk patients, and lead an implementation of quality practice recommendations, which I'll go through right away. So that leads us to the second objective. We're going to look at the evolution of quality metrics in OB anesthesiology. So recall this excerpt from the UK's surveillance system, the Embrace system. Anesthesia causes contributed the minority, and none of these were direct. All of these were indirect. So what is the current state across the pond here? So there are very few talks by OB anesthesiologists where this paper from the Green Journal is not referenced. These are pregnancy-related deaths from 2011 to 2013. Sadly, we haven't had an update from this group since then. But recall that a pregnancy-related death includes those during pregnancy and up to 42 days postpartum, and they can include those incidental and accidental causes as well. So this paper got a lot of attention at the time because it showed a trend that we are still living in North America, and that's the cause of death in and around pregnancy shifted over the past couple of decades from these classic causes of maternal death like hemorrhage, hypertension, infection, thromboembolic disease, and now to a state where most of the deaths are attributed to cardiovascular conditions that are worsened by pregnancy. This reflects a lot of our changing maternal population. We're older, me, and sicker, and also coming into pregnancy with a lot of complex diseases that probably wouldn't have survived till the age of childbearing until recent decades. So we can see here that anesthesia-related complications have really never made up a big proportion of maternal deaths, but these still have been greatly reduced over the last 30 years or so. How did we do this? So the first call to arms in OB anesthesia in regards to mortality was in the late 70s. And this was when we were seeing a lot of cardiac toxicity related to very, very concentrated solutions of bupivacaine and other local anesthetics. So examples, we're using 0.75% for a labor epidural. This is where we began using these dilute formulations, fractionated dosing for our epidurals, and the simple change really drastically reduced the number of maternal deaths. After that, we focused on general anesthesia in the 80s. So although the increasing use of epidural analgesia during labor was really widely reducing our reliance on GAs for C-sections, the rate of maternal mortality when someone did have a GA was unchanged. And it was attributed 2.5% of the pregnancy-related deaths in the US at that time. Deadly aspiration and failed intubation were the biggest culprits. And then in the 90s, we really focused on reducing the incidence of aspiration. So using medications, using our fasting guidelines. We were largely avoiding GAs at that time, thanks to using regional anesthesia, early epidural placement for high-risk patients, and then using difficult airway algorithms. Better airway equipment has really driven down the incidence of anesthesia-related death, for which we are now at 0.2%, which is our current state. So although death and the maternal mortality rate is obviously a very important metric, it's obviously not the only thing that we care about. Calculating the incidence of severe complications associated with anesthesia has been difficult to do for the same reasons as following the death rates. Most of these are very rare outcomes, and the record keeping is really fraught, and a death certifier isn't going to have a lot of understanding about anesthesia specifics when it comes to serious outcomes. So this is a landmark paper in OB anesthesia, and it's known as the SCORE project. SCORE stands for Serious Complications Related to OB Anesthesia, and it was performed by the SOAP Research Group. They sought to determine the incidence of these complications in order to gain better insight into risk factors. So we all were familiar with the dogma of aspiration being very dangerous in pregnancy. Difficult airway is going to always lead to problems. They said, let's do our best to actually capture the incidence of this. So you can see that their list of serious complications does include death and cardiac arrest, but also other complications such as aspiration, failed intubation, and high block. This was measured prospectively over 5 years, which is pretty unique. 30 academic institutions submitted their cases from their quality assurance program. So they reviewed over 300,000 anesthetics and 5,000 GAs in accordance with this. So they didn't rely on ICD coding or death certificates, which was pretty unique. And what did they find? So of all of these 300,000 cases, they identified 157 serious cases. Actually, interestingly, 85 of those, so almost half of them were anesthesia related. And surprisingly, the highest incidence of complication came from high neuraxial blocks, 58 of them in total, respiratory arrest, which was not related to airway manipulation, and unrecognized spinal catheters. Interestingly, there were 0 cases of aspiration related to GA. However, 1 in every 500 general anesthetics resulted in a failed intubation, but none of these led to hypoxemic arrest. So the findings inspired this follow-up study, which is still ongoing. SOAP now has a general anesthesia for cesarean delivery registry where institutions are invited to contribute data about individual GA cases. This started in about 2017, and they're still collecting data with the hopes to have a really nice big data set on GAs and cesareans to better flesh out these trends and isolate how often these feared complications actually occur. So all of this is very on brand to the 2010s, where we saw the big data era come in. We're using our EMRs to collect massive databases in the US. Examples of some that reach nationwide include MPOG, you might have heard of that, or NACOR. We've just joined MPOG at Stanford in our main OR, and we're going to be joining it soon with our OB data as well. It can't really go without mentioning AI when it comes to big data right now, and we're going to be seeing that definitely make a big impact on these big databases. So that SCORE project was very interesting because it was prospective, but we do have to use caution when using these big databases in a retrospective way, because as we've seen, data is only as good as the data that we enter. So Canada right now does not have a specific anesthesia residency. We obviously have a lot of government information that comes from the Canadian Institute of Health Information. So the answer to the SCORE project in Canada comes from this group in Toronto who took on the CIHI database and attempted to look at the incidence of serious complications associated with OB anesthesia. So this was retrospective. They used ICD coding to look back at 13 years of data specific to anesthesia, and much less well-defined data. You can see that one of the categories that was overarching was cardiac and central nervous system complications due to anesthesia. So that was the most specific that we could get in reference to things like high blocks or complications with our spinals. Overall, the complication rate that they captured was 0.3% of all OB anesthetics, declining over the years, as you could see there. The most common serious complications were PDPH and failed or difficult intubation. They didn't see any deaths that were directly attributed to anesthesia-related events. So this paper was accompanied by an editorial that highlighted some messages that I think are really relevant at this point in time in Canada, when I know that particularly at this institution, you're on the verge of getting EMR. So, quote, while electronic anesthesia records are still early in their implementation in Canada, now is the time to develop a core data set relevant to OB anesthesia and realize the potential of EMR for quality and outcome research. Data must be standardized and validated to ensure we are comparing apples with apples and not epidurals with general anesthetics. Furthermore, outcome metrics need to be reflecting patient-centered outcomes so that we can provide the best care for all pregnant women, regardless of race, ethnicity, socio-demographic background, or geographic location. So the results of these databases, along with data from vital statistics, has led to the formulation of what I call the first generation OB anesthesia quality metrics. So in the mid to late 2010s, these groups that I have listed here started to put together bundles of quality metrics that they suggested a labor and delivery unit should follow. We have guidance from the RCOA, so that's in the UK, that would be equivalent to like the CAS or the ASA. The OAA, which is also in the UK, equivalent to SOAP in the US, and then SOAP, which is North America Society for OB Anesthesia and Perinatology. So the first one that we saw, unsurprisingly, came from the UK, seems to be a bit of a theme here. So the Royal College of Anaesthetists released their Quality Improvement Compendium in 2017, and they offered guidance on which metrics we should be following in OB anesthesia and which targets we should be trying to achieve. So some to point out include achieving an over 85% success rate with block placement, and on the converse of that, having to resite less than 15% of your blocks, achieving an accidental dural puncture rate less than 1%. And for cesareans, they rely on categorization of the urgency of a C-section. So category 4 would be equivalent to a scheduled or elective C-section, so the least urgent. And they say here that over 95% of those should be under regional, and you should only be converting less than 1% of them to GA. Around the same time in the US, SOAP introduced what's called the Center of Excellence designation. This designation was created to recognize programs that achieve excellence, also to set a benchmark for other institutions and to promote the subspecialty of OB anesthesia. I think there are currently about 80 institutions worldwide that have the designation, and there are a few in Canada. To achieve this designation, you do have to achieve the rates listed, and if you don't, you have to supply some information as to why you might not be or why you're working towards it. So overall, they suggest reaching a GA rate for cesareans of less than 5%, a replacement rate of 3 to 6% for neuraxial, which is quite different from the RCOA, and a wet tap rate of less than 2%. And they also, probably more importantly, require that you have evidence of an ongoing quality assurance review. So they don't want you to send your data just as a snapshot. They want to see that you're reviewing it regularly and that you're creating some action items related to it. And lastly, from the OAA, which is this very specific subspecialty organization in the UK, they put together a bit of a different project. So they did a Delphi project where they surveyed anesthesiologists, other maternity healthcare workers, and patients in the UK to ask the question, which quality indicators can we use to support QI in maternity services? So they gave them a list of quality indicators from the literature and then asked them through a Delphi process to narrow it down to a couple that were the most important. So you can see here that the list is somewhat different from SOAP and the RCOA. There's more emphasis on patient-centered outcomes, like the time to get an epidural, or having elective cesarean section lists so that there's less delays. But there is a lot less rigidity surrounding the particular outcome metrics that we saw in the previous ones. So we started in the 2000s with defining serious complications in OB anesthesia in the US and Canada. We're now building databases that will allow us to better follow and define the incidence of these problems. And now we have organizations that recommend certain benchmarks for us to chase and target. So might there be any issues with this approach? So although the first generation OB anesthesia metrics are a great place to start, they are rife with issues. So firstly, almost any number that we've seen, whether it be GAs less than 5%, PDPH less than 2%, these are all just based on historical publications, usually from a single center. So it will be an institution reporting what their rates are. Does not mean that they have a good practice. It does not mean that we should all be achieving that, but that's kind of the best that we have right now. And then coming together to determine which of these metrics is largely based on expert opinion. So there's, aside from that Delphi process in the UK, it's largely just a group of experts getting together saying, we think that these are what you guys should be following. There's no guidance on the data analysis. So you have your number. What do you do with it after that? How do you reduce it? How do you improve it? Don't really have any guidance yet. And then there's no nuance for the institution, location, workforce, or the patient population, which, if you're a rural community with only one OB anesthesiologist, or, people are at home and they're not in-house, it's going to differ for what you can expect to achieve. And mostly these were outcome metrics. So recall that those were rates of complications and little emphasis on process and structure, except for the OAA. And that brings me to another metric that I wanted to discuss. So that of the balancing metrics. So balancing metrics, as described from the IHI, are used to ensure that change is made to improve one part of the system, don't negatively impact another part. It's a way for us to measure and monitor any unintended consequences by checking the effect of the change in different parts of the system. So these should be anticipated when you do improve your outcome metrics, and are often good reason to highlight the use of process measures. So I'm going to provide a cautionary tale with regards to the use of metrics that comes also from the UK. This is called the Ockenden Review or Report, which was named after the lead independent midwife that investigated this particular case. So previously in the UK, the cesarean delivery rate was a quality metric that was monitored, again, by government, and a range with only an upper limit was suggested as being associated with optimal care. So the particular hospital in question, which is called the Shrewsbury and Telford Hospital, boasted a cesarean delivery rate that was 10% below the national average. Because of series of safety events, including neonatal and maternal deaths, an investigation and this review resulted. So per the report, the Ockenden review revealed 201 babies that could have survived if the Shrewsbury and Telford Hospital had provided better care. In other cases, mothers died and babies were left brain damaged. So a critical issue highlighted was the hospital's misguided aim to fixate and lower the cesarean delivery rate. So they had rigidity in keeping this cesarean rate low, and that led to avoidable harms. The metric was prioritized over the patient needs. And because of this, NHS actually discontinued using the cesarean delivery rate as a metric. Overall, an unbalanced focus on the numerical targets without considering context, patient needs, and balancing measures can lead to detrimental outcomes. So should minimizing the rate or chasing a lower cesarean delivery rate ever have been a metric? Well, we know that there is a safe range for cesarean rates that includes a lower limit. So maternal mortality decreases when we approach about 19%, but it really shows no benefit beyond that. So that's why we are aggressively trying to chase down our cesarean delivery rate in the US, particularly where it's about 28%. Conversely, we see a sharp uptick in maternal mortality when the cesarean delivery rate falls below 10%. So we should always have a lower range when we're looking at these limits. It shouldn't be zero. And there's likely a sweet spot for all of these metrics. So now, can we think of any balancing metrics that might be important for the OB anesthesia quality metrics that we've discussed? I'm going to entertain two examples. So let's go back to the example of the metrics from the RTOA. In particular, let's look at the failed block or block replacement metric that they've offered. They say that less than 15% of your blocks should be recited. So as much of the benefit of having a labor epidural is to achieve a minimally painful labor experience, any anesthesiologist will also tell you the other benefit is to have the ability to quickly top up an epidural for surgical anesthesia, particularly in the setting of an urgent or emergency section. So doing this has allowed us to minimize our GA rates and provide increasingly safe care to these high-risk patients. We actually saw the mortality rate go down, right? So what do we know about the quality of this conversion process? So there's a few studies that have assessed this, and most have come to the conclusion that, not surprising, converting an epidural that really wasn't working during labor is probably not going to top up very well for a C-section. So the most objective measure of a failed epidural is the presence of several top-up boluses during labor. Interestingly, the other factor that correlated fairly strongly was the presence of an OB anesthesiologist converting it. This study was actually done at our center, and I can definitely say that through our fellowship training and most of the OB anesthesiologists, we do have generalists in our call pool. We are very aggressive with our block replacement. A lot of us have like a 2-bolus rule. New epidural comes in. So as much as that might be interpreted on the technical ability, it's really not. It's more about the active management of a labor epidural. We now have systematic reviews that summarize some more factors that correlate with failed conversion. So consistently, we've seen that these poorly functioning catheters during labor with a lot of top-ups don't convert, increased pain during labor before the cesarean. So that's probably indicative of a poorly functioning epidural. Again, management by a non-OB fellowship trained anesthesiologist, and unsurprisingly, the urgency of the cesarean, which was most strong. Inconsistent factors include a patient's increased BMI, dilation at the time of your labor epidural placement, which is probably a surrogate of a long labor, and then CSEs versus epidurals. So saying that placing a CSE during labor probably tops up better than a plain epidural. They conclude with some tips on avoiding conversion failure, which emphasizes largely replacing dysfunctional blocks early and reassessing the quality of the block often. So I'm left with these questions. If a replaced block works better for conversion, is this a metric we should be minimizing? And they're asking us to convert less than 15% of them. And if we avoid replacements, what happens to patients with poorly topped up epidurals? So let's use the same logic when we look at GA rates. So they say that for scheduled cases, less than 5% should be GAs, and we should be converting less than 1%. So what might be the issue in chasing a GA target like this? What might be a balancing metric? Now, I'm sure we've all been there. It's an epidural that's been touch and go during labor, tops up just okay. Hold our breath, cross our fingers at the incision and see how we do. And then we end up limping through the rest of the cesarean on a cocktail of supplemental meds. We spend the whole case negotiating with the patient whether they feel pain or pressure, and maybe we eventually convert to a GA. Again, it was the revolution of GA avoidance in OB anesthesia that really drove down our mortality rate, right? Or our contribution to it. Well, a lot has changed during that time, and we do have some new information. This systematic review concluded that 15% of women receiving supplemental analgesia or anesthesia during elective cesarean deliveries. They've also noted that this includes descriptions of pulling and tugging, and not only that sharp pain that we're often looking for. So the first attempt at a guideline to manage intraoperative pain during cesarean delivery has come from France in the past few years. So they offer a workflow to prevent and avoid intraoperative pain. A lot of that is focused on replacing these dysfunctional blocks during labor, but they also give a framework for us to deal with conversion to GA during the cesarean due to intraoperative pain. And they define pain as any circumstance where under neuraxial, the patient requests additional medication. Again, they're trying to avoid the definition of pain that often has this paternalistic approach. And this was accompanied by an editorial, and I love this quote. "It is important to listen to and believe the patient when she complains of pain, and it is equally important to take action. Telling the patient that the anesthetic is working and that what she is feeling is just pressure and is normal is not good enough." And I've definitely come full circle on my tolerance for discomfort during cesareans, and I've taken a approach that one of my colleagues has when he teaches our residents and fellows. He says, there's really no purpose in flushing out what type of pain they're feeling. We can't tell them that if it's visceral or if it's tugging or pressure. He says, lie down, close your eyes. I'm going to stand over top of you, put my thumb on your eyeball, and use all of my force to push on it for an hour. That's not sharp pain. Is that uncomfortable? So the rise of these descriptions and research on intraop pain comes alongside the rising acknowledgement of a mental health crisis amongst peripartum women. In fact, ACOG estimates that up to 20% of postpartum deaths are from suicide, which is emerging as one of the leading non-obstetric causes of maternal mortality. And when we look at the contributors to maternal mental health issues, we know that birth trauma and PTSD are major causes of postpartum depression and anxiety, which in turn are the biggest risk factors for postpartum suicide. This systematic review gave us some odds ratios associated with experiences with PTSD development and found a couple very strong indicators. So the intensity of pain, peripartum complications, emergency C-section, and complications with anesthesia had some of the highest associations. And this is a case that actually really changed my practice. It's really too bad. The OAA used to have a video online that you could watch. It was an interview between their president and this patient named Susanna Stanford. So Susanna experienced significant pain during her C-section in the UK. She was having it scheduled for placenta previa. And after independently dealing with the trauma and the PTSD herself, she eventually reached out to the OAA to say, I want to tell my story. I want to make change for other patients. And she now speaks as a patient advocate and actually spoke virtually at the CAS last year. It's really a harrowing story from the outlook of a patient that goes home with this trauma. And although you can't find the video anymore, I'm not too sure why they took it down. She and Dr. Bogod, who's the president of the OAA, put out an excellent paper on her experience, and these quotes have stuck with me. I had a life-saving procedure and my son was all right. I have a keen sense of perspective. However, I remember nothing of the first year of my son's life. I never sought a diagnosis, but my experience was consistent with the symptoms of PTSD. For years, I experienced flashbacks, irrational fears, and wanting to avoid certain situations. My impact was felt by the whole family. My sons had a mother who was physically present, but in other ways was absent because I was numb and disconnected. So we learned that most of the maternal mortality from anesthesia occurred from GAs, and we did a very good job in beginning to avoid them alongside making them safer. We have less GAs, and we have metrics that encourage us to avoid them and keep that metric down. But we're starting to notice, or at least acknowledge, as I don't think it's been a big secret, that a lot of women experience pain during cesarean deliveries. Now, with evidence correlating these experiencing PTSD, depression, and anxiety after, and a growing maternal mental health crisis, have we come full circle here? Might it actually be deadly in some situations to avoid a GA? And it's because of this that the ASA has recently released a statement on pain during cesarean delivery. It's a really great read. They offer guidance on preventing and minimizing the risk of pain during C-section, but don't encourage us to avoid it. They have guidance on the conversion and conduct of a GA, but also emphasis on what we do after that. They quote a lot of the same literature that I've discussed here, highlighting how our safe care for pregnant patients under GA has become increasingly safe, and how minimally these classic risks of aspiration and failed intubation are actually occurring. And they do recommend following some metrics, including a GA rate, but also things like the percentage of patients who get systemic analgesia during C-section, which may be the balancing metric that we've been looking for. We actually have just implemented an icon into our EMR that says intraoperative pain. So if we have a patient experiencing it, we just fire it, and that will allow us to follow up and retrospectively see how much this is occurring. And because there hasn't really been a good prospective study that determines the actual incidence of intraoperative pain, keep in mind that that big systematic review is A, retrospective, but B, was looking at adjuvants and medications given as markers of pain. We are awaiting the results of this big multi-center study by the SOAP Research Network. So they prospectively collected data on the rate of intraop pain and characterized the type of pain in the patient experience as well. Other studies, as mentioned, have used these surrogates. So this is really going to be the first one where we see the actual incidence of pain. This was presented at SOAP this year, and it won Best Paper. It should be published soon. So this is probably going to really help give us some insight there. And this brings me to what I'm calling the second generation OB anesthesia metrics, which currently only consists of this statement on quality metrics by the ASA. These came out in 2022, and they're quite a bit different than anything that I've shown before. So they're very comprehensive. They cover a lot more ground than anything we've seen. They do contain these classic outcome metrics like GA rate or the replacement rate, but there's a lot more patient-centered process metrics and balancing measures. So here we see supplemental analgesia as a balancing metric, how long it takes to receive an epidural after request, dosing and education around opioid consumption, which is obviously timely during this opioid epidemic we're living through. They also cover a lot of ground on post-dural puncture headaches, including the proportion that go on to have a blood patch and how soon they receive it after they experience a headache. And I wish I had more time to talk about PDPH because that is a topic that has markedly evolved in recent years and shows up as a metric from almost all of the agencies that we've seen. No longer do we simplify this as a nuanced headache, a self-limiting complication. We have really solid evidence that PDPHs are associated with chronic pain and significant postpartum morbidity, back pain as well. We do have guidelines on PDPH management in OB, and I encourage everyone to look at them. They walk you through a framework for determining when you might need imaging or consulting neurology. And they also do a nice summary of what the long-term complications might be and how we should be counseling patients when this happens. All right, and the last little bit here, I'm just going to give you a bit of a snapshot on how we use metrics on our labor and delivery unit. And again, if you're at the precipice of having EMR, how you might want to think about building this in. So there are several ways to do this, but in my opinion, the best way is to build this right into your EMR. At Stanford, we switched to our current EMR in 2015. We use Epic. And I'm very thankful that I had very wise predecessors who demanded that in the initial build of our EMR, we built in a QA process. So for every patient encounter, every epidural, every C-section, every cerclage, whenever anesthesia gets involved with the patient, this information needs to be completed by the attending anesthesiologist before they can close the chart. So we have a bit of a mixed bag of metrics that we follow. Some of them are the classic quality metrics that we've talked about already. Some of them are markers of severe maternal morbidity, like hemorrhage or ICU transfer. But the key is that we review this on a regular basis as a division. So here's an example of our PDPH rate, hovers somewhere between 1% and 2%. We review this weekly with our residents. So we give our residents access to the database from the week prior. And we have a little QA rounds on Fridays with the residents where we just go through the prior week and discuss the cases in a really informal manner. And then on a quarterly basis, our fellows present this in a division meeting and provide some analysis. We often have a group discussion about any trends that we do or don't like and action items that might inspire a QI project. Here's our neuraxial replacement rate. So you can see that we hover somewhere between 5% and 10%. We do exceed the SOAP COE criteria, even though we are a center of excellence. Theirs was suggested to be between 3% and 6%. But again, I said that we are really aggressive in replacing blocks, and we're not ashamed of our replacement rate whatsoever. In fact, we're proud of it. And one last little piece of data that just tells a cool story. It's a graph detailing our anesthetic type for cesareans. So yellow is CSEs, green is epidurals, GAs are brown, and then spinal anesthetics are orange there. So I was really surprised when I got to Stanford. We do a lot of CSEs for our cesareans. We have very long surgical durations. And we ended up getting to a vicious cycle here where, because we were anticipating a lot of long cases, we started putting CSEs in because we thought we might need to top them up. Turns out that we rarely have to top them up. That spinal lasts a good 90 minutes. But we had them in place as a safeguard. And it became kind of an emotional security catheter for everybody involved, including our OBs, and that they ended up requesting CSEs. So it became this vicious cycle where they were requesting them because they thought they needed it. And we, would just comply, and ended up that we were doing a majority of our scheduled cases under CSE. And our residents actually got really bad at single shot spinals and that they were much used to doing CSEs. So you can see here how we, stretched ourselves. And then when we saw this trend evolving, we got together and said, this is ridiculous. Let's change our practice. Let's do some education. Let's go back. Let's, analyze our actual rate of epidural top up from a CSE, which was minimal. And we've actually, kind of returned to our baseline there. So we're doing slightly more spinals again. So overall, if you want to get started with QA on your labor and delivery unit, take guidance from all of these agencies that I've listed here, but take it with a grain of salt. As mentioned, none of these metrics are validated. The rates are just suggestions. It's more important just to pick something to follow and actually just capture your current state. Develop a means to collect and review data through your quality assurance program. And I really suggest that when you're building your EMR, that this be something that you look into. Engage your OB anesthesia members in determining the targets and outlining action items. And then when you determine that there might be a problem, this is where you can reach out to an improvement science specialist. And I think you guys have one for your division. We can't do it all as clinicians. This is where you can bring in expertise and actually get help for making the change. So in summary, our data is only as good as those interpreting it. We have several nuances in our maternal mortality data in Canada and the USA that warrants review. There is value in maternal mortality inquiries and surveillance groups, and anesthesiologists should be a part of these. Quality metrics in OB anesthesia are still evolving and require scrutiny before, during, and after their implementation. We should always be looking for balancing metrics, and we should choose what is best for our institution, not just what these agencies say. And finally, setting up a QI and QA system at your institution requires early buy-in and sweat equity, but it will be meaningful for your patients. Every presentation we do is a recruitment, so if anybody's interested in doing an OB anesthesia fellowship, feel free to email me or scan this code. Our application starts in January. And then SOAPS meeting, the Society for OB Anesthesia and Perinatalology, is in Portland this year. I am going to be doing a workshop on QI and QA that's targeted for generalists at the beginning of it. But for any residents, this is where I got started in the community. I did a case report at SOAP when I was a resident and kind of got adopted at that point.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.